السلام عليكم and بسم الله الرحمن الرحيم. دكتور حماد شكرا جزيلا على المقدمة الرائعة ديت and thank you for this great introduction. First things first, it's always a pleasure to be here and to witness this impressive growth of that course year over year. I would like to thank my dear brother, Dr. Abed Al-Lahabi, for the invitation and the whole organizing committee. Dr. Saad Al-Rajhi, Dr. Adel, Dr. Nawaf, they all feel like brothers, and it really makes me pleased and excited to be here. So thank you. And so that we can continue to be on time, I'll start with my talk today. We're going to be talking about advances in biliary cannulation. These are my disclosures, and these are our learning objectives today. To cover these learning objectives, we will go over why cannulation still matters, definitions regarding cannulation and cannulation techniques, what's new in biliary cannulation, advances in pancreatic access, what not to do. This will be like a bonus slide, and our escalation algorithm. Some of the videos I'll be showing today were shared with permission from Dr. Joel Munzer, so I would like to thank him for generously sharing some of these valuable teaching pearls today. So why does cannulation still matter in 2026? Several reasons. ERCP today is mainly a therapeutic procedure. With the advances we have in non-invasive and minimally invasive biliary imaging, ERCP is mainly performed for interventions. So cannulation in ERCP specifically is a very clear-cut and a binary measure for success of the procedure. It's either you cannulate or you do not cannulate. Unlike many other interventional procedures, like third space, for example, a field that I'm particularly passionate about, you might be under the impression that you have complete resection of a lesion, and you're correct, but after a few days, when the pathology comes back, that's not correct. So ERCP is very specific, and it's very humbling in that regard, is that cannulation is a very clear-cut measure for success of the procedure. Beyond serving as the primary marker of technical success of that procedure, biliary cannulation is also the most critical step. That's the step where most, if not all, the complications can happen. So it's very well known that prolonged attempts for biliary cannulation and repeated trauma to the ampulla are a clear indicator for risk of post-ERCP pancreatitis, and even risk for other complications, retroperitoneal perforation, even the risk of bleeding, and even when the procedure is prolonged at cannulation, that's also an anesthesia risk in itself, because it exposes the patient to more risks from sedation from the duration of the procedure. Before discussing the details of difficult biliary cannulation techniques, it's important to align a few key definitions here. I always love to start with definitions. And the definition of successful cannulation is basically selective, deep access, enabling therapy to the duct of choice. And in this case, we're talking about biliary cannulation. For difficult biliary cannulation, the best definition is really based on the ESGE criteria, or what's commonly known as the 5-5-2 rule, where basically if you have more than 5 contacts with the ampulla, spend more than 5 minutes, or you have 2 or more access into the pancreatic duct, and now added to that more than 1 PD injection, this is considered difficult cannulation. ERCP continues to be a very high volume procedure. In the United States, we perform more than 169,000 ERCPs annually, and across the world, we perform about 1 million ERCPs every year. So it's a very common procedure. Despite these large volumes and the impressive advances in techniques, skills, and equipment we have, still about 11 to 20% of biliary cannulations are considered difficult biliary cannulations, even in expert hands. And that's still a relatively high percentage. So in an analogy to the anesthesiology concept of difficult airway management, an interventional endoscopist has to be prepared to face a difficult biliary cannulation and should be armed with the gear, the concepts necessary in dealing with that situation. This includes rescue techniques and as well as handling of all the equipment they need to handle that situation. Failure to cannulate is not as associated as with such like the tremendous effects or immediate effects as failing to manage the airway, but still, failure to cannulate means that this patient will require more procedures. This patient might be exposed to more complications. And to understand how advanced cannulation techniques work, it's essential to review the ampullary anatomy, including the topography of the ampulla and the direction of the bile duct. So when viewed in this sagittal view of the ampulla and the duodenal wall, we would notice that the bile duct basically takes an S shape, going up in direction. And there are also several configurations of the pancreatico-biliary junction, with the short common channel being the most common, where the bile duct is superior and the pancreatic duct is inferior. The other configurations might be less common, though. Another helpful assessment is the topographical evaluation of the ampulla, or the intraduodenal portion of the ampulla. So we have several variations from short protrusion to a large protrusion. And that large protrusion is not only an indicator for potential difficult cannulation, as we see here in a study with an odds ratio close to 3, it also guides our escalation algorithm for cannulation techniques, as we will show shortly. So basic things first. The most common cannulation technique is basically engaging the ampulla with the short part of the tip of the sphincterotome, maneuvering the guide wire, so it's wire-guided cannulation, until the wire is easily advanced selectively into the bile duct. There are modifications for that technique. So another modification is basically when we use the wire, like the short wire tip, to gently kind of touch the ampulla as we're trying to cannulate. So you can advance it. In this case, after using the wire tip, we needed also to use some contrast injection. You're allowed to use a little bit of contrast injection. We know that wire-guided cannulation in general is safer, but in some situations, with the contrast injection, you can show the anatomy, and in that case, there was some misalignment with the sphincterotome. Once you see the direction of the bile duct, you can align the sphincterotome and go from there. This is the partial wire tip method, where you advance 1 to 2 millimeters of the wire tip at the tip of the sphincterotome, use that to anchor the sphincterotome at the ampulla until the sphincterotome is anchored and you're selectively into the bile duct. A less common technique is pure wire-guided cannulation. As you see in this situation, we're basically just using the guide wire to go into the bile duct. So the bile duct is cannulated before the sphincterotome is advanced over the guide wire. This is the least traumatic option, but it's not commonly used option for biliary cannulation. So what's new in 2026? The advances are mainly in the strategy rather than the techniques we use. So early algorithmic escalation, like how do we escalate from one technique to another? Utilizing our pancreatic axis, as we will show shortly, you will get into the pancreas, so what to do in these situations. And then when we decide to pre-cut, how would the anatomy affect the decision for which pre-cut technique we'll use? And then you should have defined stop rules and rescue techniques. So this is an example where we have access with the wire into the pancreatic duct, and the wire keeps going back into the pancreatic duct. So in this situation, the wire keeps back into the pancreatic duct, you're not having any access to the bile duct. It's reasonable to cannulate the pancreatic duct, get deep cannulation with the guide wire into the duct, and leave the wire there. In this situation, we need to inject a little bit of contrast because you can see the pancreatic duct makes a loop downward and then goes upward. And it's very important to make sure when you're advancing the wire, you're not going into a side branch. So that would cause excess trauma. Then the sphincterotome is removed, and once the tome is removed, we recannulate using another wire into that sphincterotome. The whole idea from the double wire technique is that having that guide wire into the pancreatic duct would straighten the pancreatico-biliary junction, that S-shaped form, and that would aid with the biliary cannulation, with selectively accessing the bile duct. Another example is when we cannulate the pancreatic duct, we can leave a stent in there. So once you leave a pancreatic stent, and even with the wire-guided cannulation with a double wire, it's recommended at the end that you leave a stent. The advantage of leaving a stent in the pancreatic duct, besides reducing the risk of post-ERCP pancreatitis, is that it also acts as a guide, where we use a sphincterotome to cannulate at the 11 o'clock position, and that ideally gives you selective access to the bile duct. So these are two techniques when you have access to the pancreatic duct, and it's essential to understand the pros and cons of every technique, and that's why we have more than one. So with the wire-guided option, you have more space at the ampulla to maneuver your sphincterotome, but the scope itself is restricted in movement because of the wire that's into the pancreatic duct. On the other hand, when you're using the PD-guided method, you have the freedom to move the scope, but if you have a small ampulla, you're really restricted. And that can be one of the situations where it's very helpful to have this partial wire tip when you try to cannulate, to anchor with that wire tip at the 11 o'clock position and then advance the sphincterotome selectively into the bile duct.
5 minutes, Moamen.
Okay. With the discount or without the discount that Dr. Hamad wanted? What if you couldn't get access to the pancreatic duct at all? Pre-cut method becomes your way. And there are two ways for pre-cut. We have pre-cut fistulotomy, as we're showing into this example, where you basically start at the roof of the ampulla, and you can move the cut either downward or upward, depending on the anatomy of the ampulla. And one of the reasons sometimes we fail pre-cut is that we do not cut deep enough. So you would notice in this example that we're cutting really deep enough, and your success sign is once you start seeing bile coming out from that area. I'll skip through the rest of the video so that we continue with our time. If you had access to the pancreatic duct, you can still do pre-cut over a PD stent, and the advantage of that is that the PD stent would help guide your cut. You want to cut into the 11 o'clock position. Another variant of the pre-cut is the transpancreatic septotomy. So as we said, there is always a small septum between the bile duct and the pancreatic duct. And the way this technique works is that you already have access to the PD, and using your sphincterotome, you will perform a biliary-type sphincterotomy that's directed into the 11 o'clock position, and you're torquing your scope to the left to cut into that direction, and that would cut the pancreatico-biliary septum, eventually allowing to bile duct access. This is another variant of the pre-cut septotomy. In some cases, the wire doesn't go into any duct, and it goes through the ampulla on the other side when you have a large ampulla. Actually, this is not a bad situation. It can be an advantageous situation. You use it to basically do that similar biliary pre-cut sphincterotomy into the direction of the bile duct, and what that does, it unroofs the ampulla so you can have better visualization of the biliary orifice, and you can eventually cannulate. Ampullary diverticula, those are challenging, as we know. This is one case where we used actually both techniques that we commonly use in those diverticula when you have the ampulla at the rim. One of them is having this parallel guide wire that you can see, passing a wire through the channel of the ERCP scope to kind of push the ampulla on one side. When that doesn't work, you can always move the ampulla, pull it outside and clip it in what we call as a clip cannulation method. And once this is done, you are adjusting and lining up the biliary axis to cannulate. We cannot forget about EOS, guided options, but since we're talking about cannulation, we're only talking about antegrade rendezvous. Antegrade rendezvous can either be done percutaneously or with EOS, where we basically visualize the bile duct under EOS, get a cholangiogram, pass a wire, coil that wire into the duodenum, grab the wire, and cannulate over the wire, as you can see in this situation. Sometimes, regardless of all the techniques you're using, all of these options wouldn't work, and at some point, you have to decide to stop. There's nothing wrong with that, and ERCP, it's like aviation. Success isn't just executing the maneuver, it's knowing when conditions are no longer safe. And we have this quote in aviation that says, a good pilot knows how to land a plane, but an excellent pilot knows when to abort landing. So it's very important to know when to stop. So what not to do in difficult cannulation? Do not persist beyond difficulty triggers. Do not repeatedly opacify the pancreatic duct. Do not delay post-ERCP pancreatitis prophylaxis. Do not pre-cut blindly or without a stable position, and do not view stopping as failure. This is our cannulation algorithm. This is basically a brief sum of what we discussed. If you have PD axis, utilize that PD axis to your benefit. If you do not have PD axis, pre-cut is an option for you. And these are my take-home messages. Define difficulty early, escalate intentionally, use pancreas strategically to your favor, match cut to the anatomy of the ampulla, and prioritize safety over heroics. And there is always another day, and thank you very much.
Excellent, Mo. We'll keep the question up to the end.
Thank you.
Yeah, so we'd like to welcome our next speaker,